Perfect. I see many of you are still logging in. I'll start by giving some key information. I'm Gabriel Altit. I'm one of the neonatologists based in Montreal, and it's my pleasure to co-chair the TNE Foundation curriculum with Dr. Daniel Rios. And so today, before I present the presenters, I just want to mention that we want to thank Mallinckrodt for the unrestricted educational grant that makes us able to support this academic venue for learning in the TNE fellowships. The other thing that I want to mention is that we do have accreditation from the Royal College of Physicians and Surgeons of Canada to obtain credits relative to the Section 1 for maintenance of certification. And I just want to also mention that towards the end of this session, you'll be able to provide feedback. And this is very valuable when it comes to prepare for us the setting of the presentations and also for the topics that will be addressed in the context of the upcoming cycles of the Foundation's curriculum. I also want to spend 1 or 2 minutes to just 1 second to thank Laura Thomas, who works on the back end in order to make these sessions run smooth for all our fellows. And so the format of today will be a first initially presentation by Dr. Faith Zhu. We would like to thank Dr. Faith Zhu for taking the time of coming here and sharing with us her expertise and experience on the matter. Dr. Faith Zhu is a staff neonatologist. She is also a neonatal hemodynamic specialist at Mount Sinai Hospital and assistant professor in pediatrics at the University of Toronto. Her area of academic interest includes the use of targeted neonatal echo in critically ill neonates and the long-term cardiopulmonary phenotypes of preterm-born children. She has published many landmark papers on the pulmonary vascular disease and pulmonary vascular phenotype of our fragile babies. So it's really a pleasure and honor to have her here with us today to share with our trainees and ourselves her knowledge and experience. So Dr. Zhu, now the stage is for you.
Thank you so much, Gabriel. That was such a kind introduction. Let me just share my screen to start us off.
While you're doing this, I just want to mention maybe for the presentation, we'll have Dr. Zhu present, and at the end, we'll have a session of questions and answer. And once the Q&A is finished, our fellows will be invited to join the case discussion. There you go. Sorry.
Lovely. All right. So thank you so much for having me here today. I'm really pleased to be here to talk to you guys about chronic pulmonary hypertension in babies with BPD. And it's really an area that's been growing in interest probably over the last decade. And I think it's now really more the forefront of many neonatologists' minds when they are caring for these babies with bronchopulmonary dysplasia. So for starters, I have no conflicts of interest to disclose, and just kind of want to talk a little bit about, over the next sort of half an hour or so, what are the things we're going to be discussing today. So often, CPH is viewed by clinicians as almost the less attractive sibling of acute pulmonary hypertension. It is, the name suggests, it's chronic, so things take time to develop, and maybe the response that we get to treatment is less instant than some of these acute PH kids that we often face in the NICU. So I'll first start off with talking a little bit about why CPH is an important disease, and then really delve into the sort of pathophysiology of CPH in the context of BPD, examining also some of the papers and studies that looked at the role of fetal shunts in the development of CPH. And then we'll cover some of the echo principles and the screening and management approaches that is out there. And then one of our fellows, Tian, who will be talking to the fellows about a case study taken from our unit. So first of all, looking at incidence of pulmonary hypertension, as you can see here in this nicely a nice diagram from one of the landmark papers from Marani, when they took 3 different cohorts across from Seoul, Alabama, as well as Colorado. You can see here that, overall the incidence of pulmonary hypertension is roughly about 14 to 25% of premature infants. And you can see here in the black, those are the patients with PH. There is definitely a link with the severity of bronchopulmonary disease, dysplasia. But also if you see here in this column, and then kids with no BPD, there certainly is a number of these kids who also do develop pulmonary hypertension. So it's definitely a very relevant disease to our very small premature babies. So what happens to these kids? And in this cohort, in this network study from Korea, when they matched patients with pulmonary hypertension to those who had severe bronchopulmonary dysplasia, you can see that the outcomes are actually quite concerning, because you see that they have a higher number of kids who have mortality or neurodevelopmental disability, as well as pulmonary hypertension itself being an independent risk factor for not just a composite outcome of mortality and neurodevelopmental delay, but also individually on both mortality and neurodevelopmental delay. So I think we've really established that this is actually quite a serious condition. And, and I think, first of all, understanding, and it's really linked to BPD, as we have also seen. So I think really understanding what drives the process is where I'm going to take you next. So we've seen the link with BPD, and this is a nice diagram that sort of displays the sort of multifactorial nature of BPD. You can see these things that there's some things that are actually, out of all of our controls. If you have an IUGR kid, or this PPROM or choreo, these are things that actually happen even during pregnancy. And there's also some genetic component as well for some of these kids to develop BPD sometimes more severely than others. And then from birth onwards and through the NICU process, you can see that things like invasive ventilation, oxygen, sepsis, inflammation, and also shunts can also have its own impact on BPD. Now, we always think about BPD as a lung disease, but actually that's a really important component as well that is sometimes overlooked, and that is the pulmonary vasculature, which is where this link with PH and pulmonary vascular disease comes in. So we examined the prenatal factors as well as the postnatal factors just in the last slide, and what is probably really important is what happens to the pulmonary vasculature. So as you can see, these exactly the same factors that you've already seen that affect BPD, can in itself disrupt the vascular growth. And it is through this disruption of vascular growth, as well as abnormal signaling of the androgenic signaling. You can see that there's abnormal function of the vasculature. You see that there's also the disruption of the growth, leading to a reduction in the surface area and the cross-sectional area of the vasculature, which can then lead to what we see clinically, which is hypoxemia in these babies. And then this elevated PVR is an important component that we'll delve a bit more into. And all of these really do end up, can end up leading to vascular remodeling, which is, again, a very important part of this process, which then leads to pulmonary hypertension. There's a little arrow I'm going to add over there, which is that we'll discuss a little bit, is how hypoxemia also leads to vascular remodeling, which is, I think, an important concept to think about, especially when we're thinking about also management strategies for these kids. So we talked about PVR, and that's a huge factor in these kids with CPH. So you guys have probably all seen this diagram on the left, but essentially when we talk about PVR, a lot of times we're talking about the net PVR. So the net PVR is a combination of both the vascular resistance of the alveolar vessels as well as the extra-alveolar vessels. And on the left here, at residual volume of the lungs, you can see here that the alveolar vessels are actually at its lowest vascular resistance. And it's the opposite for the extraalveolar vessels. And as lung inflation increases and lung expansion happens, you can see here that the intraalveolar vessels actually increase in resistance, whilst there's a slight drop in the resistance of the extraalveolar pressure, extraalveolar vessels. So really the sweet spot where the net PVR is at this lowest really is at this functional residual capacity area. So all of this sort of kind of relates to, how we manage our kids, even during the NICU stay, about trying to avoid underinflation as well as overinflation of your lungs, because that can also affect the PVR of these kids, as you can see here. The next thing was hypoxia. So acute hypoxia actually leads to something called hypoxic vasoconstriction. And the reason for this is then that if there's a low alveolar PO2, the alveolar vessels actually vasoconstrict. And the reason for that is because this is to help divert blood to the better aerated alveoli, and that's to enhance VQ matching. And that's what happens in acute hypoxia. But in a chronic hypoxic state, or recurrent hypoxic state, which is often what we see in these kids in our NICUs, is that, this actually enhances smooth muscle proliferation, suppression of nitric oxide synthase, as well as this sustained vasoconstriction. And you can see how all of these processes actually lead to this vascular remodeling aspect, and actually becomes a bit of a cycle in terms of worsening of this PVR as well because of this vascular remodeling. So what is also a really important concept in these kids is that, in pulmonary vasculature where there is a reduction in surface area, there's actually a chronic increase in hydrostatic pressures within the capillaries. And what this chronic increased hydrostatic pressure leads to is leaking of fluid into the interstitium or into the alveoli, causing interstitial and pulmonary edema, and then further reducing the compliance of the lungs, as well as increasing the alveolar capillary distance. And another important physiological concept as well in a scenario like this happens when there is persistently elevated, what we term persistently elevated capillary hydrodynamic lateral pressure, which is a bit of a mouthful, which really just describes that this increased pressure across the vessel walls leading to this increased interstitium and interstitial space, which in return can also exert its own external pressure on the capillary itself. So you can see how this increase in interstitium reduces the capillary space, again, worsening this cross-sectional area, increasing PVR in these kids who already have a high PVR state. So really, all in all, sort of saying that all these different processes that we see in terms of hypoxia or PVR really does lead to this ultimate sort of pulmonary edema picture, which is really a possible underlying feature that's really what we see in these kids with chronic PH. Now, it's important as well for us when we are, especially as clinicians who perform echoes and trying to define this a little bit more. We know that mean pulmonary artery pressure comes from different components. Is this because of increased cardiac output, so flow-driven reasons such as shunts or left to right shunts? Is this PVR, which we've talked quite a bit about just now? Or is this more to do with the post-capillary pulmonary venous pressure, which using echo is a difficult one to assess accurately, and often we use surrogate markers to determine whether there is increased pulmonary venous pressure. And this could be in the context of pulmonary venous stenosis, any LA hypertension or LV diastolic dysfunction. But again, the echo markers of these are always going to be used as more surrogate markers. So that's not going to be a huge focus of my talk, and I believe you guys have a pulmonary venous stenosis talk coming up shortly. But I wanted to sort of draw your attention a little bit to shunts. So with a couple of studies out there that have examined the role of fetal shunts in pulmonary hypertension with BPD. And in this study that was just published last year through the University of Birmingham, Alabama, when we examine these kids who have BPD PH at discharge or the composite outcome of PH with death, you can see that these patients who had a PD detected after a month of life or after 28 days of life, these were the kids, there was an association between the presence of PDA at 4 weeks as well as the outcome of BPD PH and plus or minus death. And also what is also interesting is that the increased time of exposure to the PDA shunt was also significantly related to these outcomes of BPD-PH as well as death. So again, suggesting that, you know, this chronic shunt or the increased chronic blood flow plays a component into that equation of pulmonary artery pressure as well. Locally, we also have done a prospective observational study examining some of these kids who have chronic pulmonary hypertension. So this was a study that was done looking, which was involved multi-sites across 4 different units in various parts of North America, as well as in Europe, where we had longitudinal scans of babies who were born less than 1 kilo of at birth, and we did scans at 2 to 3 week 3, so day 14 to day 21, as well as 32 weeks, and then we confirmed the diagnosis of PH at 36 weeks. And as you can see, even on the early scan, on the 3rd week of life, the presence of a PDA was certainly seen to be associated with kids with CPH at 36 weeks. And also, although it did not reach statistical significance, you can see that there's also some, the kids who had CPH were also had a increased number of, there were not increased PFO presence at week 3 of life in the kids with CPH. And when we looked at the sort of regression analysis, you can see here that what was considered typically a more than 1.5 millimeter or significant PDA, persistent PDA, this was independently associated with CPH, as well as per 0.5 millimeter increase in PDA was also associated with CPH at 36 weeks. So this was work that we presented at PAS this year that we will be publishing soon. So we talked about PVR, we talked about pulmonary blood flow, and these are the components that contribute to mean pulmonary artery pressure. So what does this mean for the heart? And that's probably the main thing that we look at when we look at the echo. And we can see here that, you know, in the context of high RV afterload, which is what these kids face, you know, there are different adaptation that the heart takes on board. So in a kid who is coping with this high afterload, we can see that they often, these are kids that present with more RV hypertrophy, so increase in the myocyte numbers as well, which then leads to the increase in actin myosin components to help improve contractility in the face of high afterload. But, you know, there are also kids who also present with RV dysfunction and ultimately RV failure. And these are the kids that actually respond more with dilatation. And as you can see here, that contractility ultimately reduces when you reach the point RV failure, and often seen with severe RV dilatation. And cardiac output also ultimately is compromised in these kids. And the tricky thing about PH and BPD is that there's just this big overlap between symptoms. These are kids who are chronically on a respiratory support, prolonged, you know, needing CPAP or maybe even intubation well beyond the 36-week mark. These kids don't feed well. But there may be some couple of subtle clues that may point us to a direction that these are maybe kids who not just have BPD, but also have BPD and pulmonary hypertension. And these are more related to RV failure and things like hepatomegaly, increased peripheral edema, as well as excessive weight gain. And this is a growth chart actually taken from one of our kids with CPH here. They can see that the weight sort of was tracking along quite nicely, but once they get to sort of almost term corrected, this exponential growth increase in weight certainly can happen. And usually, we will hear from our bedside nurses about things about how these kids are, lots of swings in their saturations, or they have this drop in their saturations, and if you catch them early, and you increase FiO2, they actually don't drop their sats so low. And this suggests to you that maybe some sort of hypoxic pulmonary vasoconstriction that's happening. But all in all, there's really that overlap between these two conditions, which are so intrinsically linked, that sort of leads me to first of all, talking about how the symptoms are mediated through pulmonary edema, which we've already shown that it's an important pathogenesis of what happens, and that pulmonary edema actually worsens pH itself through the increased pressure onto the pulmonary capillary, and that RV dilatation is a sign that the heart is really failing in the face of afterload. But how do we tell the difference? And that's where we kind of go on to talk a little bit about screening as well as management of these kids. So just wanted to, first of all, look at what are the practices like. And this was a survey done a few years ago where we looked at the Canadian Neonatal Network as well as the Neonatal Research Network. As you can see here, there's quite a lot of variability when it comes to screening for CPH. Here you can see that about half the sites in the Canadian network and maybe about 3/4 of the sites in the Neonatal Research Network actually have a routine screening policy. And in terms of their management principles as well, really also do differ, across these two networks. However, when we also look at what was the diagnostic criteria used, you can see that there may be some similarities there. And we'll talk a little bit about some of these echo findings as well. But you can see that, the flattening of the interventricular septum in systole or paradoxical motion of the septum is quite commonly used as one of the diagnostic criteria for pulmonary hypertension in this population. So what do we look at when we sort of look at echo screening? So we want to know what is the RV afterload, or how do we assess RV afterload in these kids? And also, how can we estimate using some quantitative markers what the RV systolic pressure is like and what the pulmonary hemodynamics are like for these kids? And then also, what's also important is that what is the impact of the high RV afterload on RV function as well as morphology? As we've talked about before, this failing heart can lead to dilatation as well as ultimately a poorly functioning RV. So we'll take you guys through sort of some of the echo markers and then discuss a little bit about some of the limitations of echo screening. But before I do that, we're going to also discuss the diagnosis of PH, which there really is a lot of variability. I think if you look at some of the guidelines, a lot of them are sort of geared towards more older kids, especially those that are beyond 3 months of age. And their cutoffs for RV systolic pressure will vary, and different papers that you read also have different definitions that they use for the diagnosis of PH, which is one of the challenges really when it comes to echo assessment and diagnosis of PH. Two sort of pretty important papers here examine the diagnosed PH based on the directionality of intra and extracardiac shunts, so your PDA, PFO, VSD. using a cutoff of RV systolic pressure of greater than 40, or where RV systolic pressure to systolic blood pressure ratio of more than half. And then also looking at this interventricular septum configuration as well, which seems to be the most commonly used echo marker in this population, as you can see in the different studies that I've shown you, and also in the survey that I've shown you just before. So using echo to assess pulmonary hypertension really tends to be the first line of assessment that we use. We talked about the septal wall configuration, and as you can see here, you know, in a normal curvature, we're talking about, and this is in pediatric population when they correlated with cardiac catheter. So not so much in the neonatal population. We can see that in a normal curvature, this is estimated to have an RVSP to systolic blood pressure of less than half. And when there's flattening of the septum in end-systole, this correlates between half to isosystemic with 0.5 to 1.0 of systemic blood pressure. And when there's bowing of the septum into the LV, this is usually when we see suprasystemic pulmonary pressures. Of course, there's some limitations. This is, you know, while these images look very clear, there's sometimes, you know, there's going to be some subjectivity as well between individuals when we assess the curvature of the septum. Eccentricity index is a quantitative way of trying to describe the septal wall configuration, and that is done by measuring two components in your LV. So this is your D1, which is from your septum to your lateral wall, and then this is your anterior-posterior dimension, which is D2, and the equation is usually D2 over D1. So you can see that when your septum gets more and more flat, D2 is going to get longer over, it's going to get larger in terms of its relationship with D1. Therefore, an increasing eccentricity index measured at end-systole has been shown to correlate in, again, older children with catheter measures of pulmonary pressures, but there was really very limited correlation studies done in premature babies. Now, RVSP is something that has been described as well in the literature, which, you know, gives us a estimation of the mean pulmonary artery pressure from the TR jet. And you can see here the Bernoulli's equation where, you know, 4 times the Vmax of the TR jet plus an RA pressure, which we usually, again, we don't know the exact RA pressure, but it's usually taken as 5 centimeters of water, it can be used if it's present. Now, the problem with RVSP is that it's often absent or in an incomplete jet, and that's sometimes even in about 90% of cases, or up to 90% of cases. And also its absence does not necessarily exclude pulmonary hypertension. So whilst it's there, it can be a useful tool, but it's unfortunately more often than not actually not present. And then another tool that we can use for assessment of the severity of pulmonary hypertension is actually the PA Dopplers. And this was a paper that the group here had published just this year, looking at the shape of the PA Doppler. So you can see 4 different shapes here, A, B, C, and D. So A describes more of an isosceles triangle. B describes more of a right angle triangle. C with a notched picture. And D where there's a low velocity. So in the groups A, B, and C, you can see here that there's an increasing RV systolic pressure, as well as the ratio between RV systolic pressure and systemic blood pressure, as well as RV-ET-PAT ratio, which is looking at the ratio between the RV ejection time and the pulmonary artery acceleration time, which in itself is a marker of high PVR. And you see that there's an increasing marker of pulmonary pressures when you go from groups A to C. In group D, however, this was noted to be seen in kids with low RVO as well as a reduced RV function, which could explain for this sort of low velocity picture that we see. So actually looking at the PA Doppler itself and the shape is actually a very nice and simple way of assessment of how severe pulmonary hypertension can be in these kids. And then one of the important components that we talked about on top of the morphology of the RV is the assessment of RV function. And these are two of the commonly used markers, FAC being, as you guys probably already know, it's looking at the difference in the end diastolic area, the change in end diastolic area to the end systolic area of the RV, and the percentage change during these 2-point time points in the cardiac cycle. This is often taken at the 4-chamber view, and for many people on this meeting, and we've started looking as well at the RV 3-chamber view, which is a very nice image, I find, because it actually encompasses both the inflow and the outflow of the RV, and actually helps us look not just at the longitudinal function, which is what the 4-chamber view often takes into account, but also looking at the inferior wall as well as infundibula of the RV function of the RV as well. TAPSE, as you guys know, the tricuspid annular plane systolic excursion, again a often used marker of RV function, but as we already just said with the FAC, taken at the 4-chamber view, we're really just looking at a longitudinal function of the RV as well. And because of cross fibers with the LV, sometimes we may actually have TAPSEs that are maintained, even though the function can be reduced as well. So that's one of the important limitations as well of TAPSE measurement, although it's quite simple to achieve, as well as the inter-rater reliability is pretty good usually in TAPSE. So we talked a little bit about pathophysiology, we talked a little bit about echo screening and management, and I just wanted to talk a little bit about sort of what is in the guidelines. So in this American Heart Association and ATS joint guidelines for pulmonary hypertension, it's clearly recognized that this is a significant problem in kids with BPD. So screening of high-risk patients is certainly recommended, not just from a risk factor standpoint, but from kids who just don't necessarily improve as we expect, and their lung disease course is disproportionate, their oxygen requirement is disproportionate to their lung disease, or have these recurrent cyanotic spells. An important recommendation as well from them is sort of looking at hypoxia and potentially targeting normal or SpO2 to prevent hypoxia in this population. And again, bring us back to the point of hypoxic vasoconstriction and how trying to avoid these multiple episodes of hypoxia leading to worsening of the vascular remodeling is an important piece. And also other contributory factors as well, like reflux, aspiration, any sort of bronchomalacia, trachomalacia as well. So it's an important thing to explore. And finally, also looking at cardiac catheterization. I'm not going to go into too much detail about it in this presentation, but it's certainly an important aspect of assessment for these kids, especially if we think that they have very severe disease. And also if we want to try to quantify if there's any pulmonary venous disease or what the pulmonary capillary wedge pressure is more accurately as well. So if we're talking about management of these kids, there are really 3 sort of pathways that are targeted when it comes to trying to improve these kids with pulmonary hypertension. And the 3 pathways that you see here are really the first one here is the prostacyclin pathway, and then the nitric oxide pathway, which both help with its activation helps with vasodilation. And then there's also the endothelin pathway, which works by the medications that are given for this works by blocking this pathway to avoid vasoconstriction. You'll see here that there are names of certain drugs that will look familiar to you, like milrinone, sildenafil, nitric oxide, and then more recent drugs such as bosentan have all been described and it's used in this population, but the evidence is really very limited here. Back to that survey that I showed you earlier, when we looked at these two different networks, you can see here that often people use nitric oxide as well as sildenafil as either the first or second line of treatment. But when we actually look at the evidence of using sildenafil, there's really quite limited in this population. And this is a recent meta-analysis which actually combined 6 studies, and you can see the total number actually in these 6 studies are really barely 100 kids. So really small observational studies that start this treatment also much later when when they're beyond 45 weeks corrected gestational age. So whilst we can see that sildenafil does play a role, certainly in terms of things like improving pulmonary artery pressure, what we also know from this meta-analysis is that it doesn't necessarily reduce the risk of mortality in this high-risk population. So again, I think it just goes to show that, whilst we know it's an important disease, and the treatment options are often targeted at things like causing vasodilation to improve sort of the PVR standpoint. I think one of the things that I will show you is sort of locally what we do as well, and how potentially maybe directing treatment towards the pathogenesis itself may actually have may play a role in improving these kids. But also, I think I also wanted to highlight the fact that, whilst we may be improving PVR by inducing vasodilatation with drugs like sildenafil, nitric oxide, it's also important to consider that there's also a component of kids who have a flow-driven aspect of pulmonary hypertension. And in these kids, their pathophysiology really has a much more significant component of pulmonary edema, which, the use of these drugs, may not have the same effect, and potentially, in theory, an adverse effect in that component of kids as well. So the most recent guideline that we have, and actually that will lead me to sort of some of the local practices that we've done here, is to just kind of look at how we would approach management of pulmonary hypertension. You can see here that, in these high-risk groups, and I just wanted to point out that actually in this guideline itself, their threshold for diagnosing PH actually is RVSPO 25. So you can see, again, the differences in different studies and guidelines used for diagnosis of PH. But, diuretics is actually one of the initial treatment strategies that they use, and it is interesting because it actually probably goes along with what we've talked about, that pulmonary edema plays that significant role in PH in this population. And they've talked a little bit about sort of repeat evaluation and echo, and that's important, and that will be highlighted in TNTN's case presentation as well. And then before considering things like sildenafil or other pulmonary vasodilators such as bosentan. So I just want to share a little bit with sort of our local sort of practice here, something that we have published a little bit about, and this was first published in 2018, and I think this came into practice around 2016. Where we have instituted a standardized algorithm for screening as well as management of these kids with CPH. And you can see here we start off with, first of all, identifying the high-risk group, where we perform an echo for these patients around the 36 or 34 to 36 week mark. And diuretics, again, similar to that more recent guideline that I just showed you, is also our initial therapy of choice, given the pulmonary edema piece as an important pathway to pH. And in kids who do not respond to diuretics, these are kids that we would certainly look at alongside our cardiology colleagues to consider pulmonary vasodilators like sildenafil. So since instituting this algorithm, we've had a couple of studies that we examine sort of the impact of this algorithm. And we can see here, first of all, when we looked at the short and long-term outcomes of kids with BPD or only or BPD and PH, can see here that these kids who were treated with this standardized algorithm actually had fairly comparable long-term outcomes at the sort of 18 to 24-month stage with those who do not have PH. And here, when we looked at the actual cardiopulmonary physiology of these kids, you can see here that when we compare the pre-diuretic therapy with the post-diuretic therapy, that the markers of PVR has certainly improved, where the PAT was longer, the RVT-PAT ratio also improved, and this is within a space of 2 weeks. And actually, the directionality of the shunt also improved in these kids within 2 weeks of instituting diuretic therapy. And from a clinical outcome standpoint, when we looked at sort of this cohort of patients who we treated with a standardized algorithm, actually, we had one patient who died before discharge, and that was actually more related to brain injury rather than respiratory failure. We had 10 kids who went home on home oxygen, and actually about a quarter of these kids had resolution of their CPH before discharge. And about 60% of these kids end up going home on diuretics with follow-up in the community with cardiology. And only 3 of the kids that we studied in this cohort actually needed sildenafil. So again, showing that potentially if we were to target the pathophysiology and screen early, maybe these are kids that we can hopefully avoid having to start things like sildenafil, et cetera, which are less known in the sort of preterm population, or its use and its effect less known in the preterm population, as potentially one of the strategies that we can that we have adopted over our time here. So to summarize kind of what we talked about today, so I think we've seen quite clearly that there's a multifactorial contribution towards the development of BPD and the abnormal pulmonary vasculature that we see. The underlying pathophysiology really does sort of pulmonary edema is a really main component of it through the elevated PVR or the increase in pulmonary blood flow. We've talked a little bit about echo screening and its limitations, and then finally also some potential management strategies. So the evidence for some of these are still going to be explored over hopefully the next few years. All right. Thank you very much, and I'm going to stop sharing.
Thank you so much, Dr. Zhu, for this wonderful overview of chronic pulmonary hypertension in our preterm babies. There's a few questions in the Q&A, and I see that Laura has posted to complete the evaluation and posted the link, so please do that before you leave. So in terms of one of the questions that came out is, do you recommend echo screening for CPH for all babies with a diagnosis of BPD? And I know you presented the ATS recommendation and AHA recommendation, but maybe I'll expand this question to, are there babies without BPD, but with prematurity and not necessarily on oxygen or respiratory support at 36 weeks that you would still consider? like growth restricted or other, situations that you think, oh, you know what, this particular patient may be worthwhile getting a screening, even if we're able to, get off oxygen or CPAP as per our unit guidelines, knowing that they're also very variable between units. So,
Yeah, for sure. I think that, so I think there are a couple components to this question. So I think there's certainly the high risk population, like you talk about the IUGR kids, who sometimes we may find that may present even a little bit earlier, especially those kids who have a PFO shunt, that may not tolerate the higher, cardiac output in a small kid with, smaller vessels as well. So sometimes we may find that we actually screen these kids before 36 weeks, because we think that they're just out of keeping with what we expect for them. And I think that's sometimes a bit of a flag for us to think, you know what, this kid is just not quite what we expect. Unfortunately, for the kids who come off respiratory support in our unit, and maybe in a lot of tertiary units, they're often transferred to level 2. So it's hard for us to screen them because most often, once they come off CPAP or on some low flow oxygen, they get transferred. So it's certainly, I think for practitioners who work in a unit where they see these kids for a little bit longer, I think it's certainly there will still be high risk population, and especially for the kid who comes off CPAP on low flow and then goes back on again. It's certainly, for me, would be something that will flag in my mind, you know what, maybe this is a kid who's just not that typical, that will be worth looking at.
Perfect. There's another question about the use of diuretics in the context of a suspicion of high PA pressure during your screen. And so, and wondering, like, have you encountered, depending on the dosages, I suppose, and the duration of the diuretic treatment that you're exposing your patient population, have you encountered electrolyte imbalance? Do you have a particular protocol to follow that? Calcium and, the bicarbonate and all these kind of things, depending on the type of diuretics that you use.
Yeah, so we kind of went through that sort of algorithm quite quickly in terms of what we do. So we don't actually start diuretics necessarily on every single kid that has high mean pulmonary artery pressure or estimated pulmonary pressures. Actually, those kids we think are at a point of towards RV failing, so evidence of RV dilatation. So again, kind of subselecting the population that we think is going to benefit best from some intervention and who are looking like they're not coping with this high RV afterload. So in terms of the electrolyte imbalances, so yes, we do see, kids who have usually sort of low sodiums, which are often managed with oral sodium supplements. But that's also one of the reasons why we also do a number of follow-up scans, because when things resolve, we often like to be able to help, and clinically the resolution is correlating. We try to stop the diuretics even if before they go home. So again, limiting hopefully the exposure of diuretics, as well as limiting the sodium supplement needs that they need. So we often start with Lasix or furosemide for about 3 days, and then continue with aldaxazide for a longer period of time, hopefully with fewer electrolyte imbalances. In the study I showed you, the sort of pre-post physiological cohort study that we examined, we had one kid who was an incidental finding of nephrocalcinosis, but this was a kid with a high vitamin D level, so hard to tease out where this came from. But like I said, yes, there's some electrolyte balances, but we sort of target the kids who we think need diuretics the most, so particularly those that show RV dilatation.
One of the question, and I know you presented the saturation target from the AHA ATS, which is like around 92, 94, but someone is wondering, in your current practice, do you have other or specific saturation target once they have, established kind of BPD with a diagnosis or concern of chronic PH?
So yes, I think you're right. We did show that slide about the ATS guidelines. I mean, our sort of standard saturation targets, and now unit is 90 to 95%. So that actually falls within that window. In some of the kids that we have pH, we do kind of practice more than 92 to 97% as our target saturation. That's sort of taking from some of the animal studies that Satyan has demonstrated with regards to sort of too high target saturation and concerns with sort of oxidative stress, etc. So that's sort of where we go sort of between 92 to 97 in some of these kids.
Perfect. And, follow up to that, would you recommend a change depending on altitude? Knowing that, for example, I don't know if they're in Denver, for example, but in Denver, they definitely have higher altitude. And yeah, so I'll let you answer to
that. We're pretty sea level here in Toronto.
Yeah.
And I personally haven't worked in high altitude places. That's a very interesting question. I think I don't have the answer for that. I would say in terms of, because our SpO2 really is a surrogate of what our PaO2 is. So I don't have an answer for that. But if I do come across something, I will let Gabriel know.
Yeah, just maybe I can sidetrack on this. I don't think there's any literature. I think the papers from the group of Denver have published a lot, and they are at high altitude or higher altitude, I would say, than sea level. And last time I discussed that with their group, and that was years ago, and they may have changed it. Their saturation target when they had pH was closer to the 95%, in babies that were already close to term. So we're not talking obviously about the babies that are, still preterm, but they may have changed. So I don't want to speak for them. And obviously there's a huge gap of information on this. So more research to come. There's many other questions, but we will have to go on with the next session. So what I invite you is to potentially send your questions to Laura, and maybe she can forward them to Dr. Zhu, and Dr. Zhu might be able to answer them. So just before everyone logs off, I want to remind everyone that there's the Dr. Reagan Gissinger cardiopulmonary biology course that is coming up. And so this is going to be a really fantastic session going on from November 11 to November 14. So make sure to register. It should be something that's going to bring really tremendous discussions. And I think it's definitely a must for everyone who has an interest in neonatal hemodynamics. So on this note, please provide your complete evaluation via the link that was provided by Laura online. I really want to thank Dr. Zhu for this outstanding talk and for sharing with us her insight on this very challenging topic. And I will invite our panelists, fellows, for the next session via the Zoom link that was posted by Laura in order to go on with the case discussion part of the session. And I thank very much all the other attendees for participating to this session, and invite you to join us next block for the December session. So I will close off this session and go on to the next link.
Thanks,
Thank you.
Gabriel.